When you talk about endoscopy in general, both colonoscopy, which is what people are familiar with, and upper endoscopy, which is an esophageal gastroduodenoscopy, you really only reach into the first portion of the small intestine. Balloon-assisted enteroscopy allows you to go deep into the small intestine, into areas that are normally not accessible by visual endoscopy, and do therapeutic maneuvers, which can involve removing lesions, cauterizing, sources of bleeding, and also to do diagnosis that would otherwise not be possible by the usual means. Deeper access is achieved by basically being able to, by inserting the endoscope to the small intestine, and then using an overtube with a balloon, it allows us to fold the intestine over the endoscope and over the overtube, and then use a balloon system to basically hold the intestines in place while you use the endoscope to go deeper in, and then repeating this over and over until you basically fold as much of the intestine as you can over the overtube, and that way allow you to examine more of the intestine. Being able to do the procedure and being able to perform therapeutic maneuvers while you're doing this is the challenge, in the sense that you need to have special training to perform therapeutic endoscopy, removing large polyps, large tumors in the intestine, treating of bleeding vascular lesions in the intestine. It does require a large degree of experience to be able to do it safely. But that's obviously being able to do the enteroscopy for diagnostic purposes is nice, but if you're taking the trip down into the intestine, having the patient undergo anesthesia for this, it makes sense to be able to perform a full service and be able to treat the patient without avoiding surgery, which is the other option, is to have the patient undergo surgery and have the bowel taken out by the surgeon and examined by hand, and have the treatment performed by the surgeon itself. This way the patient is managed in an ambulatory setting, so they come, they have their procedure, and they go home the same day. I started doing enteroscopy back in 2004. I trained in adults at Stanford. Then after that, we did it in San Francisco. We're the only balloon-assisted enteroscopy program in the city. It will see patients from all over Northern California. And now we're doing them here in South Carolina. The biggest advantage, obviously, here is the availability of trained staff, anesthesia, nursing staff, equipment that allows us to be able to perform not only diagnostic procedures, but also therapeutic procedures in a safe fashion in children. So the usual indications for this procedure are basically for diagnosis, in which is a diagnostic question or a doubt about specific diagnosis in a patient, treating of bleeding lesions in the small intestine, and that can be tumors, that can be vascular lesions, treatment of polyps or overgrowth tumors in the small bowel. Usually by treatment I mean removal. And the nice thing about this procedure is, with the action of the overtube, you can actually, as we'll see in some of the demonstrations, you can actually remove lesions and then go back and forth into the same area without having to remove the whole apparatus, because the overtube provides you with a safe, easy access. And it actually ends up being less traumatic to the patient's bowel than if you're trying to do this by simple endoscopy. So for a demonstration, we're going to show a couple of cases. One is a child. He has inflammatory bowel disease, long-lasting. He has been successfully treated medically, but he keeps on having abnormal lab tests and joint pain. So there was a question whether they had gotten the wrong diagnosis, and he had Crohn's disease versus ulcerative colitis. And the difference is obviously one affects just your colon, the other one affects your entire intestine. We did a full enteroscopy on this patient. That meant that we basically went down with the enteroscope to the deepest point of insertion one way to the mouth, and then we went the other way through the rectum until you'd be able to examine the whole bowel to demonstrate whether he actually did have or not any small bowel disease, by not only by endoscopy but also microscopically, take biopsies. The other case that we're going to see is a patient who had recurrent bleeding. The patient was known to have hereditary hemorrhagic telangiectasia, which is a relatively rare disorder in which you have overgrowth of blood vessels everywhere in your body. That includes your bowel, your brain, and recurrent bleeding and chronic anemia. So specifically the bowel lesions, intestinal lesions, were the one that were chronically bleeding. He was having chronic nosebleeds as well, but we wanted to go and treat his intestinal vascular lesions. And we were able to do it successfly. After a couple of sessions, we were able to ablate almost all the lesions that he had in his intestines, and the bleeding stopped.